with Mr. Lehrman there for the video cystoscopy lessons. I believe we've already covered some of this. Understanding the use of different catheters will be covered a little later on. We have a variety of catheters here. The main thing you want to do is whatever you've got is to get one in. You understand already the anatomy and some things, but we'll talk more about this, about the urinary sphincter and how to get by that with a little bit of ease. We have the technique that we had mentioned. We have different catheters, and then you're going to have to try to comprehend what is involved in the placement of a suprapubic catheter, which we find on many of our patients. We like to use the sterile technique if at all possible, but in hospice care, as we indicated on our opening statements here, you guys are under adverse circumstances, but nonetheless, try to do it like you were doing it in the hospital. We sometimes have to resort to what they call a clean technique, but what you want to do is to not introduce any bacteria on the skin or that's underneath the foreskin or that's on the bed sheets or feces that are in the incontinent patient, but to keep as aseptic as possible. Now, of course, that's common sense, and I'm sure you all do that, but we have to mention that and emphasize it. You don't want to get a bad germ in a good place. We know about the complications. One of the things I think that he indicated was the critical area here and the use of the Coude catheter. Who knows what Coude means? Oh, you're too smart.
No, I've used them.
Okay. Coude. French word. Elbow. So it has a little elbow that allows it to pass into the bladder right here past the sphincter and then here at the bladder neck. So that's why they advocate many times using a Coude. But you can get a 16 or a 14 or in a real tight pinch, maybe even an infant feeding tube that you could tape in beyond the strictures or the difficult anatomy. The main thing is the critical spot. When you reach this spot right here, you don't want to use pressure. You don't want to take a red rubber catheter, which is really stiff. You can not only go through the urethra, but what's next door to the urethra right here? The rectum. So if you say, oh boy, that went right in, you blow up the balloon and here comes feces. I can tell you right now, you're in the wrong place. That's why we always insert the catheters all the way, such as Dr. Parkettle covered, so that you have the tip coiling in the bladder and you're not going to take a chance on blowing up that urethra with the in the prostate or in the channel here. That gives you extreme discomfort in your patient, but also it ruptures urethra at that point. In a moment, we'll go through the insertion of the male catheter here using our 5P technique. In your programs there, you've got the position of the patient. You may all want to also include your position. Get the patient at a comfortable level so that you're not bent over or working on the mantelpiece. Try to have everything prepared beforehand, as we'll go through here with our catheterization kit. Once you have prepared yourself, position the patient. And the male patient, you want him as much as supine as possible. If you have a patient that's short of breath, try to elevate his head at least a little bit, turn up the oxygen a little bit. In a difficult, agitated person, tell him to get a little bit of morphine in that guy maybe 20 or 30 minutes ahead of time before you get there. It'll save you a lot of tears, yours and his. You want to have the pelvis in a neutral position with him supine. You don't want to have him down into a sunken hole in the bed with the foot of the bed elevated. You want to try to have him as flat as possible. That way, nothing's going to distort your midline approach of having that catheter go straight in and not at an angle where it could rupture the outside of the and get outside of the urethra. The next thing you do before you've even touched your set here is to just clean the beneath the foreskin, even with a washcloth or whatever, to try to get rid of any debris or whatever had crawled up there while you weren't in the vicinity. So the second P is a preparation. So we have to prepare our work table. You want to have something that is near your patient as possible, so that's within easy reach. And that's what you'll learn when we set this up as you come up and do the practical demonstration. After you have your equipment out, then you prep the patient with the out-of-4 solution that is prepared in the set. And we have a little technique that we'll show you about that so that you don't have to cross-contaminate going from one area to another. I like to have the one hand doing something and the other hand hanging on for dear life. In passing the catheter, if you can straighten the urethra out by thinking that you're actually pulling the penis on the catheter, you can be sure that it was going to go down now at a nice straight passageway and is not going to try to negotiate a crinkled tube that has a lot of curves and has to manipulate more areas than you bargained for. So in the picture here, we see it turned down in a relaxed position. What you want to do is to straighten this out in this direction so you straighten out this part of the urethra. That lets your straight catheter go down a straight path. Another thing you say, well, we didn't talk about the anesthesia, but we'll talk about that further. We've lubricated and anesthetized the urethra, and when you reach this point here, you feel the little resistance that he told you about. Now, I have a little different opinion about that. How many OB nurses do we have here? You know, at the time of the delivery, it's bear down mama. Everything goes, and they are straining, aren't they? There's nobody relaxed, and the baby's crawling out of there, right? Okay, so if you're right here at the sphincter with the tip of your catheter, you can say, please try to urinate. What do we do when we try to urinate? The sphincter relaxes. And if you've got your catheter right here at the door opens, and you can actually, whew. And in a male patient, you saw the verumontanum, the sensitive part of the urethra, the area where it's hard to anesthetize even though you've passed your lubricant down the urethra. Right there, the patient says, oh, because he's experiencing a little bit of a sting, a little bit of a burning sensation, but you felt already your catheter suddenly went by that sphincter and it's hit that verumontanum, and now it's traveling up the last 2 or 3 centimeters of the prostatic urethra. That's when you go ahead and go for the passing of the catheter all the way to the hilt. Don't let go. Inflate your balloon and then pull down the catheter gently until you feel the balloon engage the neck of the bladder. Hook everything up and you're home free. The last thing we're going to talk about is securing the catheter. And you know, I have some tips about that also, right? So let's run past this a moment. This is what they recommend that we do, of course, when we get through. Close drainage. Don't kink your catheter. Don't let the wheelchair run over it. Don't let the dog start licking it. Show them how to take care of it and always hang it. That's why they've got that little hook on it, guys. And then secure the catheter. So this is a suprapubic. We'll go by that later. But here's a I guess it's just not anatomically correct. But we do have the catheter secured with the strap. Now, on the very last page, you'll see a little dissertation on the use of the strap. We prefer to use tape. If you use the tape, be sure not to place the catheter on a traction, but realize the patient's hip is going to flex. And when it flexes, as a pull on the catheter, if you've got it pulled a little bit too tightly. So always leave a little slack. You can pull his leg up and see if you've got it before you secure it, so that you know as he lifts his leg, it's not like, oh, I got to go to the bathroom, because that's the sensation of a bladder spasm, but it's actually stimulation of the prostatic urethra that causes a feeling of urination. So now we'll back up to a suprapubic catheter, or perhaps, I don't know if I need to tell you any more about female catheterization. We'll show you a little more on the mannequin. And these are complications after they have a catheter in. Most of the time this occurs when the catheter is too tight, when it's on a leg strap that has been pulling on the catheter and traumatizing either the meatus of the urethra or the curvature as it makes that curve over the scrotum and underneath the symphysis. That's where erosion can occur and strictures can occur. So here we go. Just what we're saying. Adhere the catheter to the thigh, allow free movement, and keep things clean. Notice the suprapubic catheter goes through the abdominal wall, and oh, it looks so simple and easy. You cannot do this on your own. We have a catheter already there. Great. Somebody else took that responsibility, either in radiology or in the operating room or in a urologist specialized equipment, to get that catheter there. Now, here are the difficulties that he went through to do this. There, although we don't see it well, is bowel, peritoneal cavity, and a lining that we call the peritoneum covering over the bladder, so the bladder is what we call extraperitoneal, outside of the organs in the abdomen. So in order to pass the suprapubic catheter, they have to, number one, distend the bladder, maybe 6, 8, 10, 12, the bigger the better, cc's. If the patient is under anesthesia, that's no problem. If the patient's awake, it may be a little problem. So if you have to exchange a catheter, you're going to say, well, I don't want to pull that out and try to get back into an empty bladder. I'll never make it. The bladder's collapsed. So you want to put in at least 6 or 8 cc's, just flow it through the catheter as gently as possible with your syringe, and have your equipment ready. The Foley is there open. Your syringe is attached to it so you can inflate the balloon, and one catheter comes out and the other one goes in, because during this time, here's all that water you're putting in there coming out of the tube. But once you go down the passage, back into the bladder, inflate the balloon, and then bring it up a little bit until you feel it engage the top of the bladder, and by then urine or your irrigant is flowing all over the place. Good. Bad if you have to clean it up, but good for you, you got it where it belongs. Any questions so far? Okay, we'll break and go from here. We'll start out with the mannequin on the male. And this equipment, these are my favorite things. Everybody has favorites? These are mine. This is the lidocaine jelly that is supplied in hospice. It has the ability to maintain patient comfort in addition to the morphine that you've given him about 20 minutes beforehand. So we have that available. This is another favorite thing of mine. And I'll show you why in a moment. But I've also opened that sterilely. I don't tear that off. So you want to try to peel back pack. If you're handing one to somebody, do it this way so that they can grab it and get it out here. This is your trash bag when you get through. Oh, how convenient. I'm grabbing this right on the very tips. I didn't dig my hands down in there. And the last one here may be difficult to grab, but at least we've touched the outside of everything and we're not contaminating anything. So here comes the point of contention. We have to be able to get out that top towel without wrecking our hands into the whole place. Now realize I've already washed my hands. Okay, but they're not sterile, but they're just clean. Okay, so we're going to try to catch this on a corner and then open it out without touching it. And we use that to cover the penis. Now I've got the point of this right in the middle of the folds, and I'm put right over the meatus, or right over the glans penis, or right over the tip of the penis, just like this. Great. We haven't prepped the penis yet, have we? Okay. Next thing under the surprise box here is our gloves. So we slide that out, put those on sterilely, as you know. Grab it by the cuff. I'm sure you all know this technique. But I've got to see if I can remember it. No, I'm not going to be able to put these gloves on. They're extra small. Okay, so pretend I have gloves on, right, guys? Okay, the next thing we want to address is so I don't have to worry now because I have gloves on. Let's get this syringe out of here. You don't want to be fiddling around with that. So let's get the top off. Let's make sure our barrel is open by pulling back. You all know that as nurses more than we do. That's all ready to go. Here's another final drape if we need it. This one's got a nice hole in it if we wanted it. Sometimes in women, you can use it in half and maybe just put on the perineum. So we don't really need that right now. We'll put it over there. Here's our sterilizing equipment. We sure want that on. Opened, ready to go. Oh boy. What we need is a pair of scissors and that hemostat he was telling you about. I usually stand these up because I like to use as much of that fluid as we can. I don't want it dripping all out. Here's some lubricant. If you were doing this with a female patient, you sure want to use this lubricant to be able to dip your catheter in and keep it nice and slick. You don't want to ever put a dry catheter into anything, not even the neighbor's cat.
You want some scissors?
Maybe.
Or on the side, there's a spot.
You have gloves on, right?
Yes, I do.
Okay.
Okay, then you want to get the catheter out of here and try to handle it as little as possible. And I apologize, I realize I've already missed one step. Okay,
It's easier to do when you don't have to talk.
now my catheter's on top. I don't know why they put it on the bottom, but now it's on top. Now I can grab it when I need it. Here's this nice and open, all ready to go. My skip step was using this. Now that's not sterile, is it? But we've got to pretend that this is clean technique. The cap comes off, as you know. This goes on, and this allows gentle flow of the lubricant in the urethra. I know this is not necessary to tell you guys this, but you've got to try to realize that this is the good stuff, okay? My gloves are on, catheter's there, the bag is there, my syringe is ready to blow up, everything's going. So now we take our glove fingers and we make a little hole right here. And we make a little hole right here. And now this is your grabbing hand, this is your working hand. So what helps these slippery members keep from flying away from you is to use a little wiener wrap available at the dairy products and Winn-Dixie, and wrap this around like this so that we've got at least a sterile wrap, which is perforated, of course. It's not as good, but it's there. And then we can use our preps. And we can prep all around, starting at the meatus, go round and round. You can do this at least 2 times, sometimes 3, depending on the patient, depending on how much stuff is under the foreskin. But you want your foreskin retracted before you even start that. Take your lubricant, squirt it down. This has 30 cc's. You at least want to get from 5 to 10 in there. You see how I've grabbed this with my fingers and my forefinger right here on the sides? This nice little rim around here keeps it from sliding, but then you have to slide your fingers around, pinching between your thumb and forefinger the urethra, which is at the ventral surface of the penis. That holds the lubricant that you've just instilled in there from coming right back out. You should leave that in there at least a minute. During this minute, you can talk to your patient and say, okay, am I hurting you? Have you had any pain? Your urethra is being numbed now by this solution that you felt drip down in there. So he will give you some indication of what he's feeling, and you can say, in just a moment, I want you to try to urinate, and I'll tell you, I don't want you to urinate a lot. I know you can't urinate, that's why we're doing this. But try to get just a few drops. You're preparing him to open his sphincter. Then you drop back over here. Grab your catheter a few inches from the end. Get your little finger over here, and you've got it. You can wiggle it around, and it's not going to fly away from you. Then you usually get about right here. I don't think this is going to pass, Karen. Give me a little man and a big catheter. Okay. So then we give it a little pull. I mean, you don't have to pull him out of the bed. That's all right. I'm not. This is not going to go. But anyway, let's say I'm passing it. We get down to about here. You release your grip, of course. Then you've got to go back with your fingers and hold on to the catheter once again. See, so it won't fly back out while you get another grip about here. Usually it's at the second one that you pass about this far, and you meet the obstruction, or you meet the little resistance. But realize that we've pulled this straight up. We still have it straight. That's what I meant about straightening out the urethra. So at this point you say, okay, Mr. Jones, pretend like you're in the bathroom and you're going to urinate all over the room. So as he does that, you apply just a little gentle pressure. And he says, okay. He doesn't know whether he's going or not, but at that moment you suddenly feel, whoa, there it goes. That's when you don't stop. You take your hand and keep right on going. If you meet another obstruction, it could be at the bladder neck. He can't do a thing about that. You've just got to try to manipulate it around. If you've got a coude, you can flip it this way. You can flip it that way, but it should go right past that. And as the doctor indicated, you go all the way to the hilt. And as you get there, you pinch again like this. It's not going anywhere as you look for your syringe that you've hidden from yourself. Put that on. Inflate the balloon. And then pull it out till you feel it resistance where it's caught to the bladder neck. If urine's not flowing, what do we do, doctor? That's a problem. All right, so you can either crimp your tube in here, what I call a closed irrigation, keeping it tight so nothing's going to go past that spot, and then swish, 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 swish. If you had lubricant in the end of the catheter, that's pushing it out and letting the urine come back in as you release this. That doesn't work. Take it apart. Use your little leftover water. Maybe you left 2 cc's in here. Good. Squirt one in, draw back. Nothing. Squirt the other one in, draw back. If nothing's happening, you may not have it all the way in. It may be something wrong with the system or with the catheter. But still, rather than giving up, I usually will let it sit there a moment, let the patient relax, let everything kind of settle down. And as you fiddle with the drain bag, getting it straightened out, sometimes a miracle happens and the urine starts flowing.
Well, mine did after about a half an hour.
Good.
I was like, wait.
It's a
wait, I was
miracle,
getting
see?
nervous 'cause it's like, but it did.
Okay.
Eventually, yeah.
The last thing we want to do is the strap for the leg bag. We've talked about that. Why don't we like to have the strap? And the reason is, if you look at your neighbor or yourselves, you can see that your thighs are tapered. So here you are putting it up in the widest part, and as soon as they stand up and that muscle contracts, it gets smaller, that slides right down. That puts a nice little tug on this, and you've seen it, and the patient is totally miserable. First thing is they tell you, I have to urinate all the time. My catheter's not working. And you look under the cover, and here it is. You've got the answer. Loosen it up, replace it if necessary by deflating the balloon and pushing it all the way in. Any questions on that part? Okay, guys. Let's go to the ladies. You asked a good question on the film. Now this one's already got the catheter in. So everything was easy. Look how much longer this catheter is once it's in the female. If you ever see that in the male, you can say, well, I know the tip of that catheter is not where it belongs, right? So you can many times tell at a glance what's going on with the patient. Now with the gloved finger, if you haven't passed this catheter, realize that we're dealing with the urethra, which is at the top of the vaginal area here. And you want to pass your finger, lubricated of course, beneath this. Now this is the sphincter, this symphysis pubis. So if you pull your finger back a little bit, you feel a little bump. That's what he was telling you on the video that got cut off. If you feel that bump, that's the opening of the urethra. Then you take your lubricated catheter and you pass it over top of your finger and you try to get it to ride up over the tip of your finger that you can curve a little bit like this, and it will get into the urethra and then pass that short distance into the bladder. I don't think you need to pass it all the way to the hilt in a female, but do give yourself pretty good room in there, okay? The same thing holds as far as adhering the catheter. You don't want to have these catheters in usual circumstances hanging down like this, because that'll erode the bottom of the urethra straight into the vagina, and then they're totally incontinent. You don't want to have it up like this. That's going to rest on the clitoris here and make them totally miserable. You've got to maybe head it out with a little slack like we talked about. But doctor, she keeps pulling her catheter out. Okay, this is going to go underneath the thigh. Same with the male, but you want to try to isolate this area either with your Chuck's pads or somehow to keep their hands out of there. Any questions?
No, we have to have our prescription for the lidocaine, so obviously when we're in a home, it's a little after the fact, so you try to keep up with that. When we, is it possible to maybe make that as part of our standing orders to have lidocaine for catheter insertion, because we have catheter orders as needed?
I know. We'll need to go to higher authority on that one, probably to Mike.
When I was looking at
some that actually have lidocaine in with the kits. They have lidocaine in in like a little syringe.
That would be good, and label those male catheters,
That would be really nice.
size 16 or 18. The other thing that would be really good is if they put Coudet catheters in there. Let's get a Coudet here and show you what's going on with that. Boy, has that got an elbow. This rush catheter, sometimes the material is a little softer and it may not pass as easier. Or if you say, well, that's going to go down a straight passage, that's a pretty good curve on it. Might not work as well, but we have to deal with what we got, and we would try to do that.
Is that the only brand we have?
All I know, you have to talk with accent about that, but it's okay.
What do you think about the silver-tipped catheters? Do you think that they're really beneficial or not the silver?
All right, so now we're going to talk about infection. Silver inhibits the growth or the adherence of the bacteria on the catheter, therefore cutting down the catheter-associated urinary tract infections. But I gave you some good quality information on what is infection, what is colonization. That's bacteria there that are not harming anybody. They're living in symbiosis with the body's system. They're not causing fever. They're not causing any irritations. So read this information over, and they're even going to have a little thing in there about how the cranberry works. We say, oh, well, I know that. It's acidification. No, it's not. Read that article, and then your patients come by and they said, oh, she's got bacteria in the urine. Well, no kidding. This thing has been in a short urethra more than 48 hours. Bacteria are going to work around it, and they're in the bladder. No matter how hard you try, no matter how much prep you put here, you're still going to get colonization. So is that harmful? Probably not, except in rare circumstances of a Proteus infection. Proteus is a bacteria that will split the urea that's normally found in the urine to allow incrustation to start occurring on your catheter or bladder stone to develop. It may take months for this to happen, but we don't usually like to have Proteus in the bladder. If we have no choice, then you just have to change your catheters a little more often. Which brings up another question. How do I know when to change a catheter? Do we do it by the book every 30 days? I hope not. But we have to if we ever worked anywhere else but hospice. You take your catheter, and right here at the connection point, let's use this one. You don't do this every day because you'll never find out any information, but maybe once every 2 weeks, if you take this, collapse it, and then roll it between your thumb and forefinger. If you can feel grating in there, sand-like things, you've got incrustation up in here. That means pretty soon that catheter is going to block up and you need to replace it. If it's slick, like the mucus that builds up, and you see that in the tubing, that may not be all bad. That's the bladder or the body's reaction to the inflammatory situation that goes on either with colonization or the presence of a foreign body. So the slick stuff is good unless it's super thick. Then they're not drinking enough liquids, and you may have to irrigate it now and then. But usually there's no reason unless there's a big gooey thing in the bladder when you first put a catheter in within the first 3 hours or 3 days to actually make you take the catheter back out.
Back to the cranberry, what is it about cranberry?
I'm going to let you tell me, because I gave you the article to read. It's fantastic. I know, I just gave it to you. So those things you read about, and also read about the pharmacy bulletin from Ocala Regional that tells you about the use of antibiotics. Antibiotic abuse is rampant. We're losing our antibiotics. We have too many resistant organisms. I've heard this over and over, and I'm sure you have too, from anybody but your patient's families. He's got cloudy urine, let's treat it. Well, you've got other things that make cloudy urine. glass of milk, Ensure Plus, all the phosphates from these things go through the urine and make it cloudy. So that doesn't always mean infection, but you can have bacteria overgrowth in there and it has cloudy urine, but does that mean you have to treat it? The idea is every time you give another antibiotic, you're not going to take the catheter out. You're going to have a colonization of the ones that survived that antibiotic, and now you've got another resistance. I saw a patient yesterday's a lab result, one drug left, all the rest resistant. They said, well, this patient has long-term catheter. Am I going to use that drug now? Patient's asymptomatic, just cloudy urine. You want to use your last bullet? You want to save it if that patient gets sick and remove the catheter and say, let's pray that that takes care of the sepsis and it's not a terminal event. So try to save your bullets. Try to convince your families that, and read the article to back you up. You've got this information, you've got the good techniques behind you, you're an RN, you know it. Don't let them tell you what to do. But do it gently, as you know. I mean, you guys do it better than I do. So let them know what's going on, that yes, you will see cloudy urine, yes, there are bacteria in it, and yes, they are friendly bacteria and they're not going to harm us, so we don't want to start harming them. You're welcome.
The tubing and the bag turn blue, I know it's a reaction to
Yeah, it's a certain thing. I don't know if it's Pseudomonas or another bacteria. I think Dr. Sharp knows the answer on that one.
But we don't have to change the bag tubing every time it turns blue.
I wouldn't.
Because it just continues to turn blue.
Okay, so we use what you were asking for, the
Cranberry.
cranberry, to decrease the bacteria's ability to infect the bladder. In other words, it doesn't kill the bacteria, it just takes their ability to hang on and make a colony and then make infection. So it'll cut down the bacteria, fine. There's another combination drug that I turned over to Mike the other day that may be an inexpensive tablet for patients to take that has a combination of methenamine in it, a couple of antispasmodics, but also a methylene blue coloring agent. So blue pills come in here, blue urine comes out there. But it adds an extra thing to kill bacteria. To be honest, it only works good in patients who carry residual urine in their bladder. They don't empty their bladders all the way, but they're urinating well enough, and this would be an ideal pill for them to prevent infections.
So not really for someone with a catheter.
Right. Whether he approves this and we get to use it or not, we'll wait and see. It just depends on the cost and how much savings we can save with that rather than using an antibiotic and another bullet.
I have one other thing. I always was taught to inflate the balloon before putting it in the patient, because once in a while there's a balloon on their foliage. So I inflate it and then deflate it to make sure it's working properly before it gets there.
I think with the catheters we have nowadays, most of them are reliable unless you've got one that's been out of date a few years and you're just praying because it's your last catheter that it's going to work. But I don't usually test the balloons anymore.
Another question. One time in my career, I've had a patient with no penis. He had cancer. Is there any, I had to replace the catheter a couple of times. Is there any, in case anybody ever has this, is there any difference or anything that we need to be aware of?
Yeah, it's sort of a in between female and male, right? So you may have to pull the scrotum up until you can see where the opening is and then pass your catheter at that point. But again, don't forget the lubricant, because you're going to find it goes through the sphincter and then into the bladder.
Wouldn't that be almost the same as a patient who's extremely obese, though? You're kind of along the same lines of having to really kind of navigate to find.
That's why positioning first is important. Lay that patient down, say, family member, come here, I got a job for you. Hold this up. Don't let go. So I can see what I'm doing down here.
I had one whose scrotum and penis perineal area was so swollen from overhydrated at the hospital with liver and kidney failure, that it was unable to advance.
Hand me the man. Great. All right, so he told you about this. Once again, I don't like to put things up off the floor, forget that. But once again, try to get something that is less likely to slip because you've got a mess down here. If you can see what you think is the end of the penis poking out, what you want to do is to push back toward the base of the penis.
Right.
And that allows a little bit to extrude. Once you've done that, then you can use your grasp technique and don't let go. If it's still a lot of edema, then you put your hand around and do the squeeze and hang on for maybe 3 to 5 minutes. Try to divert their attention, talk about the TV shows, whatever you have to do, but maintain your grip. If it's painful, get some ice in a glove, put the ice on first, then squeeze the whole thing, and the edema will slowly subside enough, and in an uncircumcised male, you can then begin to pull the foreskin back and show the area that you want to work with, and then pass your catheter as usual.
To represent PercuVision and the direct vision system and show you how that can help you a little bit with your difficult catheterizations out in the field. Start with the beginning here. We have a kit that has all of the necessary tools in it. We have drapes. Dr. Thoman talked about maintaining sterility in difficult conditions as you all work in. You have a couple of drapes, you have a drainage bag, you have masks, a couple sets of gloves, iodine wipes. You have pretty much everything you need. And then you'll have a catheter, and it is a coude tip, so you'll notice it is curved. We have right now the 14 and 18. The 14 is the green, and the 18 is the red. And as you notice, it's a tri-lumen. So you have one port that your visual guide goes in, and then you have your irrigation or for voiding, and then your inflation port. So same thing as you always have it. 100% silicone and marked. And what I'm also just going to let you know exists is a Y port and a guide. This is generally used by the physician or PA, mid-level, high-level person, generally beyond the scope of nursing, depending on what your protocol is for using wires. But this allows you to, when you get into a very, very tight stricture, to advance the guide wire, and then through the stricture, you can go up into the bladder, and then put the catheter through with great confidence. If you saw Dr. Pericottle's discussion on the filiforms, I think, well, gee, you have a wire, we can visually see the wires in the right place the first time, and then you can put it over. That one, I guess, scares me a little bit. Because it is silicone, there is a syringe, and what I've done is I've just taken, this is a visual guide port, and I put water through there just to allow the silicone, it's a little sticky. And if I could get a volunteer, since you're closest, Jennifer. Jennifer, never stand in the front of the class. You should have learned that early. Normally you'd be doing a blind insertion. I'd like you to, talk to your patient here, and you don't have to talk to them, but try and put it in as you would normally would.
I'm going to cram this in. It's not going to feel good.
Okay, as you're
Usually I just tell them take a deep breath, and I just keep going and doing and doing.
okay.
And
Now
I got past one. I could feel
you're
it.
hitting some resistance there. Okay, now what would you normally pull back and
Normally
try
I would
again?
pull back and I would turn it and try to reposition it and causing trauma for my patient.
Is he hollering at you right now? What are you doing to me? And okay,
Yeah,
and
it's not going in.
okay, you use in the field a straight tip. This is actually a caudate tip, so you have a little advantage here with this one, although you're not familiar with it, but allows you to kind of do some steering. So, but that's okay. You can give up. The patient's hitting you or yelling.
Kicking and screaming.
And believe me, nobody's been successful. Actually, no. If anybody did that, I might eat my words here. But that's typical, and we're cheating a little bit here. There's no lubrication there, so I cheated in some degree. However, I'm not going to use lubrication with this one either. So now, try the visually guided system. And as you can see, it's a 0-degree scope. Don't blind yourself, but you can see how the caudate is pointing up. If you insert it with that pointing up, and with this model, because it's a little opaque, you'll kind of see through it. But see how you want to keep it turned so that you can keep the urethra in the center of the picture there if possible. And I think it's still, so you can see the stricture coming up here, right there. And then you can turn a little bit to go through that. There's another stricture. You're going past that. Okay, and now guess where you're at now?
All the way in.
You're in the bladder.
Yep.
So
That's
what
really
was the
cool.
difference with that? It's extreme, and we
It
didn't use any
was.
lubrication. We didn't cheat too much on anything. But part of it is, I think, knowing what you're coming up against. But when you can see a stricture, it's except for the sphincter, which is generally in the center. Most strictures are going to be offset one side or the other. So with the caudate tip, what that allows you to do is, as you're coming up and you can see it's offset, you just turn it, and as you navigate through, you kind of, as a little trick, you just start turning it back, and it kind of straightens out, and then you're through. So keeping oriented with your vision into the center so you can see the urethra just kind of push down. You can always see ahead of yourself. Now, we're going to have to work out, so as you can see that stricture coming, when you got stuck on that the first time, I mean, you're applying a little more force. You're telling the gentleman, I'm going to apply a little force. You're trying to work with it, but in the back of your mind, you're being very cautious because you don't want to cause trauma and injury. And what we're hoping to do is, rather than if you really couldn't get through, is there such a stricture you couldn't get through, now Dr. Thoman could come out and use the guide wire, and I've got a couple of videos I can show here, which are different than Dr. Paracolite, because these were just done in the last couple of weeks by Dr. Singh, and so very, very tight stricture. In the first one, he's actually dilating a patient that came into the ER, and then there's two more, but you can see that's actually the guide wire out in front of the catheter. So when you have irrigation in a hydrophilic catheter, it basically like floats on the water. And you can put that all the way up into the bladder, and then with a lot of comfort, extend your Foley, because you know that the guide wire is up in the bladder, so you're going to follow your guide wire. So it's pretty simple techniques will allow you to get more difficult catheterization. So if you needed to call him because you couldn't get through, if you had a stricture that was really, really tight and you couldn't get through there, rather than back and forth and really causing, traumatizing the patient and causing all the bleeding and elevating your potential for infection, he could come and use the guide wire. Everything's all set up, and then hopefully be able to do the catheterization there and save transporting the patient and to have it done. I mean, I think that's the key is there's two things. One is reduced infections, which I understand you have a very low infection rate, which is amazing based on where you're working out of. But number two, the cost of transporting patients and coming in and just for Foley. I mean, there's obviously a lot of reasons why you need to bring patients in, but we shouldn't really have to do for the Foleys. Do I have some other victims, other volunteers? Mary, you look like you've done this before. Come on, step up to the front. Now I picked on the first row. Now I'm going to the back row.
Yeah.
So do you want to try and put one in blind first?
Sure.
Well, close your eyes then.